So today we'll identify and name many of the non-motor, or what I also call the invisible symptoms of Parkinson's. We'll discuss the impact of a few particular ones that can be really tricky, as well as some treatment strategies for those tricky ones. It's interesting. We used to call Parkinson's the prototypic movement disorder. It's the most common sort of movement disorder in treatment. But over the years, I think what I have realized is I spend a lot more time treating the non-motor symptoms than I do the actual motor symptoms. And I think the impact of them is very broad. We'll also entertain as many questions as we're able to at the end. Next slide, please. So again, as I was saying, the motor aspects of the disease, these are the ones that we can see: the tremors, the slow movement, the changes in gait. These are things that we can all appreciate, and they're easy to see. But as you look at the iceberg, it's much larger and even more daunting underneath the surface, where you can't really see it. It's hidden, if you will, but that does not mean it's real. People with Parkinson's suffer from a lot of different non-motor or invisible symptoms, including sleep disorders, changes in speech, changes in their mood and behavior. Sometimes things that are really difficult for patients to even be able to describe and communicate to us. And so I think it's always important to have a discussion like this. I always tell folks, don't go looking for trouble where there isn't any, but just be aware that these are some things that you may notice, and bring them to my attention, because there's a lot of things we can do to try to treat them. Next slide, please. There have been a number of surveys done over the years that have shown that that more than 60% of Parkinson's patients feel like their invisible symptoms are more disabling than their visible ones. We did a survey in my clinic back in Georgia about 15 years ago, and it was one question: what is your most disabling symptom? And we were all kind of taking bets. Is it going to be balance? Is it going to be tremors? What is it going to be? And it was a little over 60%. I think 65% said it was actually their mood, their emotions, depression, anxiety. Those were the things that people felt more crippled by than any of the physical challenges that Parkinson's might be giving them. So I think I realized back then, this is stuff that you got to pay attention to, because someone may have a shaky hand, and if I'm focusing all my attention on fixing that, I may be completely missing the boat on what is really causing the most issues and maybe the most impact on a particular patient. Non-motor symptoms, the invisible ones, are a major impact on caregiver strain. I think for caregivers, caretakers, it's hard to understand what people are feeling and going through if they don't communicate it. It's easy to see that somebody's not walking well, and say, honey, have you taken your medicine today? But kind of understanding what are some of these non-motor issues that can come up, so caregivers have a better sense of how can I help my loved one. And even for us clinicians, we don't always ask about these things. We don't always discuss the impact and how to treat them. Sometimes it's an issue of time. How much time do you really have in an office visit? And you got to get across the most important points. And folks may kind of come in with a list of things they want to discuss. And is there time to get through all of them? I think that's important to do, is to write down the things that you want to discuss, because we want to get through all of them, not just the top two. And I think in a traditional practice, that's what one of the challenges is. But historically, the non-motor symptoms, the invisible ones, these are the ones that are tricky. Sometimes they're really challenging to treat. They don't necessarily get better when you just give more Parkinson's medicine. Most of the dopamine type therapies, most people are taking levodopa in some form. It doesn't really address the non-motor symptoms. So you have to really reach for other things, other medications, other types of therapies, other specialists, involving people who are skilled at memory care, involving people who are skilled at behavioral health issues. Having a team approach to that is very important, because I don't think any one of us necessarily has all the answers. Next slide, please. So here's the laundry list, so to speak, of the non-motor features of Parkinson's, or the invisible symptoms. So there's a whole host of cognitive and psychiatric symptoms that people may notice: anxiety, depression. Some people just say, I feel more apprehensive doing things that were so simple years ago. Maybe I get really stressed out driving. Maybe going to the airport, just with so many people moving around in different directions. I just can't handle that anymore. And it's not a sign of weakness. Dopamine, the same chemical that modulates your movement, has a profound effect on your cognition and on your emotional state. People often describe a lot of fatigue. I just saw a gentleman this morning. His biggest problem is fatigue, and if he could just have more energy and feel like he was more awake, life would be pretty good. But we actually use medicines to try to stimulate and wake people up, if you will. The thinking can get affected. Sometimes people describe it as slowness of thinking, or I'm not processing information as quickly, or perhaps multitasking is a little bit more difficult. It's almost like on the computer or on the phone, when you're trying to search for something and just the hourglass is kind of spinning. You'll get there. It just may take a little bit longer for you to get to the right spot. We see a lot of changes in sleep with Parkinson's. Some people will get more sleepy. Some people will get insomnia. Some people wake up in the middle of the night for no good reason. We see a lot of changes in the dream state, a lot of really vivid dreams that some people start having, even to the point where they're acting out the dreams. Often they're violent dreams, kicking and punching and screaming in your sleep, where it's not only disrupting the patient's sleep, it's also disrupting the spouse or the family and the sleep that they're all getting. We can see a lot of hallucinations, not just in the middle of the night or out of sleep, but even during the day. Hallucinations can occur in many people with Parkinson's. The disease itself can cause hallucinations. The medications we use can cause hallucinations. So this is something that we commonly ask about, because they're very treatable. Usually, especially when one of our medicines is causing it. But there are medicines to treat the hallucinations when it's really just the Parkinson's that's doing it. We see a lot of what we call autonomic side effects or symptoms from Parkinson's. This is sort of like the body's equilibrium in a sense. So, we see people who have changes in their sweating patterns. Some people just have drenching sweats for no reason at random times of the day or at night. Some people stop sweating. We can see changes in blood pressure regulation, and this is a tricky one that we'll focus in on a little bit more. But orthostatic hypotension is a situation where the blood pressure drops with changes in the position, usually from sitting to standing, and this can be really debilitating, because if your blood pressure drops too much when you stand up, obviously you get dizzy, woozy, you feel weak. It can also get low enough that people can pass out. This is something that can be very disabling and very unpredictable at times. So important for us to measure. And people always ask, why does your nurse check my blood pressure when I'm sitting down? And then she makes me stand up, and we should do it all over again. And I know it's not a lot of fun to do it, but this is why, because we're always looking to see, does your blood pressure drop when you stand up? We can see sexual dysfunction both in men and in women from Parkinson's. So it's something that if you are noticing those things, bring it to our attention, because there may be things we can do about it. Skin changes. Some people, their skin may get drier. Some people, it's more oily. A lot of different things can happen. Constipation is a big one. Parkinson's can affect just about every part of the GI tract, all the way from, the esophagus, where, we're connecting from your throat to your stomach, where you're swallowing. You can have dysmotility, or lack of contraction, or lack of movement. So sometimes it's harder to swallow things. It just won't go down. Sometimes you're aspirating, it goes down the wrong pipe. Then you have your stomach. The food goes into your stomach to be digested and broken down, but just like the muscles in the arms and the legs can get slow, so can they in the GI tract. So the digestion can get slow, and things in the stomach may take much longer to get into the small intestine, and then from there into the large intestine. And so constipation can be a big issue there. Um, we'll talk a little bit more about it, but this is one of the main reasons why there can be such an erratic um, uh, absorption of your medication. People say, "Gosh, I took my medicine. Usually it kicks in 30 minutes, but it's been an hour and it hasn't yet." And it's often because the pill hasn't even gotten where it needs to go. The levodopa is absorbed in your small intestine, in the first part of the small intestine that's called the duodenum, and sometimes the pill's still sitting there in your stomach and it hasn't even gotten there, and it's been an hour. So when the gastric motility gets slow, it can really affect how your medication works. Um, there's a whole list of sort of sensory, unusual, vague symptoms that people describe that we kind of chalk it up to. We can't find anything else that's causing it, so it's probably the Parkinson's, but we don't really know why. But just vague, tingling and unusual feelings, and feeling of like restlessness. You can see some different kinds of aches and pains sometimes. Definitely a lot of people lose their sense of smell, often even before any of their physical symptoms show up, sometimes 10 or 20 years before. Actually, a friend of mine that I trained with, we were taking, there's a smell test that you can take for Parkinson's, and it's called the University of Pennsylvania Smell Identification Test. It's a scratch and sniff test of 40 different items that you can take, and we kind of self-administered it to each other. And thankfully I got a perfect score. I'm a high achiever, but one of my friends, he scored really poorly, and then we laughed back then and said, "Gosh, you should go ahead and start your levodopa now." 2 years ago he called me and said, "You're not going to believe this, but I've been diagnosed with Parkinson's." And so, these are things that often are sort of pre-motor symptoms. It happens before anything else shows up.